So good morning, everybody. My name is Joseph Guevara. These are my colleagues here. This is the coordinator team. Daniel, Alex, she's our supervisor. This is Aileen, Joey. My name is Joseph. This is my capstone presentation. I did it on neonatal ventilation. It's called Selecting the Correct Mode of Ventilation for the Neonate. And this is for the Department of Respiratory Therapy, University of Cincinnati, Dr. Bington. So here's my introduction. So neonatal respiratory distress is critical. The correct ventilation mode is vital for outcomes. And the focus of this presentation is effective support and the complications reduction of such support. So here's the historical background, part one. It all started in 1963 with the death of Patrick Kennedy. Patrick Kennedy was John F. Kennedy's premature baby. He was a 34-weeker, and he developed RDS. And at the time, there was no treatment for RDS, so they ended up putting him in an oxygen tent, and it didn't work very well. So with his death, initiated federal support for research into newborn care. So they established the National Child Health and Human Development Services from his death. So with that, development of artificial surfactant was found, and the evolution of neonatal ventilators and the improvement outcome for premature infants. So now you're seeing, like, these days we can even revive 22 weekers, 23 weekers, 24 weekers, but back then it wasn't even viable. So understanding neonatal respiratory distress syndrome. So it's caused by immature lungs and surfactant deficiency. And the symptoms include grunting, flaring, retractions, hypoxemia, and it can lead to respiratory failure without any intervention. And here's the physiology of surfactant. So surfactant, it reduces surface tension in the alveoli, it increases lung compliance and gas exchange, and it's critical in premature infants because they lack natural surfactant. And here's a few pictures of how surfactant affects ventilation and oxygenation. And there are a couple different methods of artificial surfactant administration. So the most popular is called the Insure method, where you intubate, you administer surfactant, and then you extubate, which is shown here on this picture. But lately, or recently, there's the less invasive surfactant administration, where they intubate with angiocath, administer the surfactant through that, and extubate right away. So they found that this LISA method is a lot better because it reduces the need for intubation and complications associated with intubation and administering sedatives. So that's why LISA methods is a lot better. But they would leave like the CPAP on the baby while they do this, so they don't lose alveolar recruitment. It's a little different. And so there are different types of non-invasive ventilation. So there's the high flow nasal cannula. So this is like a popular version here. It's called the OptiFlow system. It's by Fisher-Paykel. And it delivers heat, humidity at a specific flow rate to decrease work of breathing. It's more comfortable and it's less traumatic compared to CPAP. But this is for your mild cases. Like if your baby was really working, you'd start here, maybe work your way up to CPAP. So CPAP delivers a constant pressure through nasal prongs or nasal mask. The bubble CPAP method is popular, uses a water seal, and the baby breathes against the bubbles. And it's effective in respiratory distress, and it reduces the need for intubation. But there are other types of CPAP. You could use a ram cannula and use a ventilator CPAP as well. So here's a non-invasive ventilation, also known as NIPPV, non-invasive positive pressure ventilation. So you deliver a peak inspiratory pressure in a PEEP with a nasal interface. You could use a ram cannula, or you could use like a Hudson interface. And it could be synchronized with the neonate's breathing, and it reduces failed ventilation. So you can actually set ventilator parameters non-invasively with this type of ventilation, and it reduces the need for intubation. And here we have invasive ventilation, and here are the indications. So Invasive ventilation is indicated when non-invasive ventilation fails or distress is severe, and the criteria is hypoxemia or hypoxia, poor spontaneous effort, and airway compromise, like if there was like Pierre-Robin syndrome or some type of airway issue. And then intubation is followed by mechanical ventilation, either in the volume control or pressure control mode. So the invasive ventilation modes include volume control, which ensures a constant tidal volume, pressure control, which maintains constant pressure to achieve a volume, and then you have, in conjunction with those, assist control or the SIMV option. So AC is more of a control mode. SIMV allows the patient to breathe intermittently in between the set parameters. So they could draw in their own breath in conjunction with the set breath. And then here we have a few types of special ventilation systems here. We have the high frequency ventilation, the high frequency jet ventilation. It uses jet bursts at high rates, low volumes, and it's used to treat air leaks, meconium aspiration, lung hypoplasia, like for extreme prematurity. You're looking at your smaller infants, like 5 to less than 1,000 grams. And it works with a backup system. So most systems use something called a cross vent, which sets like a peak pressure and a PEEP in your FiO2 in conjunction with the jet breaths, and that's to prevent atelectasis. With the jet ventilation, it uses the Bernoulli's principle to ventilate. So there's a special adapter at the end of the ET tube, which is shown here on the left. So it uses like that high pressure, not necessarily high pressure, but the high velocity to get through the small airways. And that's why it's good for air leaks. And here we have the high frequency ventilation, high frequency oscillator. So this high frequency oscillation ventilation delivers constant mean airway pressure with superimposed oscillations, and it's used for PPHN, PIE, meconium aspiration, or if the baby is failing conventional mechanical ventilator. It's a lung protective strategy. It uses small volumes at rapid oscillations, and 1 hertz is equivalent to about 60 breaths. So if you're setting a hertz of about 15, looking at close to 900 breaths there per minute. So to set your initial high frequency oscillator parameters, you would set 2 above the conventional mean airway pressure. So let's say your mean airway pressure on conventional was 10. You'd set it at 12. And then you want to start, depends on the size of the baby. Bigger babies use like about 10 hertz. So that's high frequency oscillation ventilation. Next, we have the adverse effects of ventilation. So with ventilation comes side effects. And the first side effect is that we're concerned about as RTs, or as RTs, is volutrauma. So volutrauma is overdistension. It's an injury that causes overdistension in the alveoli. And second, we have barotrauma, which is a high pressure injury. And then you have BPD, bronchopulmonary dysplasia, and PIE, which is pulmonary interstitial emphysema. So basically, the lungs get overstretched, causes some sort of parenchymal damage, they heal, and it impedes gas flow. And here off to the right, you see a diagram or a picture of PIE. And basically, the alveolar components pop, and you'll get like a presentation on the x-ray, like off to the left there. You see like a lot of air pockets all throughout. So we try to prevent that by limiting the pressures, limiting the volumes administered to the baby. So it's important to make the right clinical decision. So the ventilator mode per gestational age is important, but really it's up to the team, no matter what the type of ventilation strategy is, to really monitor the baby. Read your x-rays, look at your gases, wean those pressures. A constant assessment with imaging, labs, and observation is crucial. And the skill and teamwork of the team will make a difference in the outcome of the baby. Conclusion. So survival depends on early recognition and the proper strategy. Non-invasive preferred when possible, invasive in severe cases when non-invasive does not work. And ongoing education and vigilance is essential for the best outcomes. And here are my references. Thank you.
Good job.
Thank you. Oh, before I end, are there any questions? Questions? No. That was my literature review. I worked on that the last few weeks. And yeah. Thank you, everybody. Thank you.
Yeah, good.
Thanks.